Okay, and now I'd like to move it on to Kathy, who will be who will be moderating for Dr. Dams O'Connor's talk today.
Hello, everyone. So I have the great honor of introducing our next speaker, Dr. Kristen Dams-O'Connor. Dr. Kristen Dams-O'Connor is director of the Brain Injury Research Center of Mount Sinai, a clinical neuropsychologist, Jack Nash professor in the departments of rehabilitation medicine and neurology at the Icahn School of Medicine at Mount Sinai, and the project director of the New York Traumatic Brain Injury Model System of Care. She has published over 150 peer-reviewed manuscripts and chapters on traumatic brain injury treatments and outcomes, and has presented her research internationally. Her primary fields of clinical and research expertise are in long-term outcomes after brain injury, intersections of traumatic brain injury and neurodegenerative diseases, neuropsychological assessment, and cognitive rehabilitation for individuals with neurological diseases. Her research is currently supported by federal grants from the National Institutes of Health, National Institute for Disability and Rehabilitation Research, and the Department of Defense. The title of her her talk today will be Studying IPV in the Community, Screening Health Disparity and Premature Mortality. So I'm all excited to hear about Dr. Dams-O'Connor's work here.
Thank you very much, Kathy, for the introduction, and thank you to the planning committee for inviting me. I'm going to go ahead and try to share my screen. Can we see it?
Yes, thank you.
Okay, great success. Thank you again for having me. I am giving this talk from my home where the neighbors are doing something in their lawn, so I apologize for the background noise. I'm a white woman with brownish, blondish hair. I wear glasses, and I'm wearing a white jacket. And I'm doing that because I Googled, and you are allowed to wear white after Labor Day now, it turns out. So here we are. I'm very grateful again for this invitation. I'm going to go ahead and jump right in, starting off with gratitude. The first slide here shows a list of some of the funding agencies and grants that have supported the work and made a lot of this possible. I will note that none of these grants are specifically designed to support research on intimate partner violence. That remains an enormous source and contributor to the research gap that I think many of our panelists mentioned earlier. But as we do as researchers, we get scrappy and we make it happen, and we do the research that we're passionate about, even when there aren't funds to support it. Just as a contextual framework, so as Kathy mentioned, I'm a traumatic brain injury researcher. So a lot of the work I'm going to be talking about today is presented through that lens. This is my expertise. This is my clinical training, is working with individuals with brain injury. So I want to just start off here defining some of the key terms that I'm going to be using just so that we have this shared nomenclature that I'll use throughout the talk. When I say repetitive head impacts, I'm referring to repeated exposure to the head or to the neck that can occur over a prolonged period of time. People often think of contact sports like football when we talk about repetitive head impacts. And when we use that term, we're usually referring to events that do not, in isolation, meet diagnostic criteria for a traumatic brain injury. When I use the term traumatic brain injury, I'm talking about really any external force to the head or to the neck that can result in a loss or alteration of consciousness. You'll also often hear the word concussion used, sometimes interchangeably with traumatic brain injury, although concussion tends to refer to the mildest forms of traumatic brain injury. Many in this audience are very familiar already with the sequelae of head trauma that can range from mild to quite severe. It is reasonably well established that most people recover completely from a single mild traumatic brain injury. Repetitive head impacts, we're really still learning about the recovery profile and the potential longer-term sequelae of repetitive head impact exposure. Now, A lot of my research focuses on long-term effects of traumatic brain injury and its intersections with neurodegenerative diseases. And this really began 15 years ago, around the time when the Institute of Medicine came out with their report where they said with strong conclusion that traumatic brain injury increases risk for Alzheimer's disease in particular, and for dementia more broadly. So early in my research, I set off to investigate these questions with more detail in other prospective studies, especially studies that include autopsy cohorts, which is really the gold standard for diagnosing neurodegenerative diseases. And across these studies, I repeatedly did not find an association of traumatic brain injury with Alzheimer's disease. And in many cases, I wasn't seeing that association between traumatic brain injury and dementia of any subtype. Now, this early study, as you see, no significant findings. We looked very carefully at the time. This was the largest study of associations of brain injury with late life dementia, and we didn't find an association. And again, as researchers, when you don't find what you expect, you try to replicate those findings. We then had the opportunity to repeat very similar analyses in a much larger cohort. We combined data from 3 longitudinal prospective studies of cognitive aging, the Adult Changes in Thought study out of Washington, and then the Memory and Aging Project and the Religious Order studies out of Rush University. And together, this is easily the largest prospective study that investigated these associations. And as you see here, we did not find in this autopsy cohort, so we're talking about gold standard neurodegenerative disease diagnostics, we did not find any association with the first two rows that you see are Brock stage and CIRAD score, and those refer to essentially tauopathy and beta amyloid plaques. They're kind of the hallmark diagnostic criteria, diagnostic features of Alzheimer's disease neuropathologic change, and we didn't find any association. What we did find, though, is increased risk for microinfarcts, which are kind of little strokes in the brain. It's a vascular type of pathology. And we also found Lewy bodies, which are associated with movement disorders, especially Parkinson's disease. So the message that we're starting to put together here is that the neuropathology of traumatic brain injury later in life does not appear to be Alzheimer's disease, but it's also not nothing. It is perhaps not best characterized by any of these traditional neuropathologies that are included in standard neuropathological diagnostic workups, but doesn't seem to be Alzheimer's, definitely not nothing, and seems to have this vascular component. That study I mentioned where we combined the autopsy data from the 3 large studies, we wanted to just be sure that what we were really studying was the late effects of traumatic brain injury. And so we limited our last round of analyses to only include people in the TBI group who sustained their TBI before the age of 25. And as you see, we replicated those same findings. So late effects of TBI do not appear to include Alzheimer's type neuropathologic change, but definitely a signal there for microinfarcts and for Lewy bodies. We went back to the first cohort that I mentioned, the Adult Changes in Thought study. That was where I really started some of this work and where we found those negative findings. Negative not being a bad thing, but negative meaning we did not find an association of TBI with dementia, because we wondered if one of the reasons for that null finding was that the way that they were asking about TBI history in that study might have not been detailed enough. They essentially just said, have you ever hit your head so hard that you lost consciousness? Yes or no? And we know from a lot of our research that I'll touch on in a little bit, that the way you ask about brain injury matters a lot. And they kind of asked it in the worst possible way, essentially relying almost on the participant to be able to self-diagnose a traumatic brain injury as if they necessarily know what that is or how one would be diagnosed, especially if it was never treated or diagnosed formally. So we added the brain injury screening questionnaire to this study, collected a ton more data. I think they added it back in 2015. And what you see here on this slide is a reanalysis of a larger autopsy cohort where we had much more detailed TBI exposure characterization data. We were also able to speak with the family members of decedents. We had medical record data. So we essentially triangulated all available sources of information about traumatic brain injury history. And what you see here is we find no associations with these traditional neurodegenerative disease autopsy endpoints. What we do see is much greater atrophy. So atrophy is a very nonspecific neuropathologic finding, but it's a very commonly observed in the brains of individuals with a history of traumatic brain injury, because atrophy, essentially shrinkage of the brain, can happen when there is diffuse shearing and tearing of axons and damage to the white matter microstructure of the brain. So why am I telling you all of this? I'm talking about this as sort of an introduction to this topic here, because people who are living with a history of brain injury think about this stuff a lot, it turns out, especially because so much of this work on traumatic brain injury related dementia and Alzheimer's being a consequence of brain injury, a lot of that made it into the popular press, into lay media. And of course, as many of you know, in the mid 2000s, we started to hear a lot about chronic traumatic encephalopathy, which is the neurodegenerative pathology found in some contact sport athletes, especially American football players. And so as a clinician treating people with a history of brain injury, I can certainly vouch for the fact that this is on the minds and hearts of people living with brain injury and their families. And that includes many individuals who sustained their injury in the context of partner violence. Now, the slide that I have on the screen right now shows a visual depiction of what I mean when I'm talking about post-traumatic neurodegeneration. And this, I think, is a really important distinction, because what we have found is that a lot of the, not all, but a lot of the studies that for all those years were finding an association between traumatic brain injury and Alzheimer's disease, or between TBI and dementia, were essentially complicating or conflating the acute effects of a traumatic brain injury with a degenerative progressive disease process of dementia. So when you use medical records, for example, to do research, sometimes it happens that the diagnostic codes that are entered into a person's chart may be the same codes used for dementia and for cognitive impairment after a brain injury. Now, we know that many people who have a brain injury resulting in cognitive impairment, a lot of them get better. And those individuals do not have a neurodegenerative progressive disease, but that distinction is not always made well when you're using medical records. Similar things have been done in studies of very different designs. But the point that I'm making, I guess, is that if a person has chronic effects of a brain injury that are stable, so someone sustains a traumatic brain injury, recovers to some degree, but still has some lingering cognitive deficits that are stable, that don't get worse over time, that individual doesn't have dementia. They have stable cognitive impairments. And that's a really important distinction too, because when we're researching and studying and eventually treating post-TBI neurodegenerative diseases, it's really important to understand what it is that we're treating, who needs that treatment, and what are the mechanisms underlying a decline that some people experience after recovering from a brain injury. Now, the thing I just want to point out on this slide, and then I'll move on, is that our research and that of many others does indicate that there's a subgroup of TBI survivors who continue to improve. that subgroup doesn't get a lot of attention in the media because it's not as interesting of a story. But gosh, that's a really important message for people living with brain injury, to know that there are individuals who recover. And as a researcher, we're trying really hard to include people who are doing really well in our studies, because we really believe that we can learn as much from people who are doing well after head trauma as we can from people who experience enduring symptoms or even decline. Now, I'm going to talk for just a few minutes about the late effects of TBI study. Divya mentioned this in her talk, because this study provides the foundation for a lot of the work I'm going to talk about here. This is an NIH-funded initiative that essentially endeavors to create a traumatic brain injury brain bank. And we're doing that primarily by enrolling people who are alive. Now, when we first started this in 2013, I think a lot of people thought that this was the most ridiculous way to begin a brain donor program. But it is the only way to do this if your goal is to be able to diagnose and to treat post-traumatic neurodegeneration during life. You have to study people while they're alive. You have to study them very carefully with study visits that can last a few hours, because we're doing neuroimaging and cognitive testing and motor testing and a blood draw. We need those multimodal sources of data to try to understand the different phenotypes of brain injury and to understand the contributors to the decline that some survivors experience. So this is an overall schematic of the LETB study. People come into our center. It's a multi-center study at this point, and we follow them longitudinally. And individuals in the study make known their wishes for brain donation. And there's an entire protocol that we conduct on the donated brain tissue that I'll talk about later on in this talk. Now, we've already begun to do a lot of research using the data we've collected during life. Dr. Raj Kumar, who's on the faculty in the Brain Injury Research Center at Mount Sinai, did some very fancy statistical maneuvering using the extremely rich clinical data we've collected on this cohort. And we're talking all kinds of cognitive tests, self-reported surveys, interviews, performance-based motor testing. And he found that there are essentially 4 subtypes of individuals living with brain injury. They can best be characterized, according to the data we have in this study, as people who, all the way over to the left, those are the individuals who are doing pretty well across the board, across every domain, almost every domain that we studied. The next column of people are those who are having a lot of cognitive impairment, but they're doing pretty well on neurobehavioral and emotional symptoms. The next group over is kind of the opposite. They're having a lot of neurobehavioral, neuropsychiatric, emotion, mood symptoms, but they're doing pretty well cognitively. And then the 4th group, all the way to the right, are those individuals who are doing pretty badly across the board, in the sense that they're experiencing ongoing symptoms in all of those domains. Now, this is really important because this maps to my clinical experience. I don't know about others on the call who treat individuals with brain injury, but it is one of the most heterogeneous clinical diagnoses that we have in our toolbox. So I have a patient who says, you know, you've seen one brain injury, you've seen one brain injury, and it's really true. At the same time, there are these sort of like common shared phenotypes, and identifying those is really critical for trying to understand how we can best conduct research and offer clinical interventions that actually map with that individual's symptoms. So you have a person who like their clinical symptoms best align with the second group here. They don't really probably need an intervention for depression and behavior dysregulation. Switch it up, and that's a poor alignment too. So we don't want to just say, okay, you have a brain injury, here's the treatment for you. We need to understand how we can align the symptoms that an individual is experiencing with the treatments available. Okay, here's where we get into how our team got pulled into and then really passionately hell-bent on making a difference in the space of partner violence-related brain injury. So it happens that our research center, the Brain Injury Research Center, is co-located with a faculty practice, the Rehabilitation Neuropsychology faculty practice. So in the same physical space, we have research studies going on and people coming through our studies. We also have people coming in for treatment. So many of our researchers are also clinicians who see patients. We have for years been treating individuals who sustain brain injuries in the context of partner violence. And like a lot of clinical research, our observations of our clinical patients compelled us to do research because we were frankly very surprised at how little was known. When you're a clinician and you see something surprising or different, you tend to like go to the literature. Maybe now you go to like ChatGPT and it just tells you everything. But we'd go to the literature and we weren't really finding a whole lot about the neurological consequences of brain injury that was sustained in the context of partner violence. We are seeing a lot about the mood symptoms, the sort of contributors to violence, how people or why people stay, some of which seem to have a little bit of a gaslighty, victim blamey kind of tint to it, but we were not seeing useful or informative research on the neurological and neurocognitive effects of partner violence related brain injury. And that surprised us because what you see here on this slide is a visual depiction of like what we were seeing in these individuals. So in many cases, the same person had sustained isolated traumatic brain injuries as a result of being pushed or kicked or punched. So hit on the head, loss or alteration of consciousness. Those same individuals also talked about, being shaken violently by their partner, being their head being hit into a surface over and over and over again. We're talking about repetitive head impacts there. That starts to sound like what maybe some contact sport athletes experience. The same individuals in some cases were also experiencing non-fatal strangulation or other types of like suffocating injuries to their brain. Now, we saw these individuals and we treated them with the tools available to us, but we kept thinking like, how can this possibly be the same thing as isolated moderate to severe brain injury, which was experienced by most of the other people coming through our center? And so we wanted to learn more. As I mentioned, we turned to the literature. And when you look at these slides, these are like screenshots of some of the studies that we found. They're 100 gazillion years old. The titles are horrifying, like conjugal disharmony. I don't know if there's a more like euphemistic term for horrifying violence. A strangled wife, like I can't. So this is what we had to work with. And the bar was pretty low. And so we knew we had a lot to contribute here. Divya mentioned this effort that began, gosh, almost a decade ago at this point, but like many things, took a while to come to fruition. We knew that if we were going to try to study partner violence related brain injury, we needed to be able to identify it. Our research center, which was led by Wayne Gordon for many, many years, had this legacy in having developed this screening questionnaire called the Brain Injury Screening Questionnaire. What it does is it uses contextual cues to facilitate recall of lifetime events in which a person may have sustained a brain injury. So it asks things like, have you ever hit your head when you were on the playground? Have you ever hit your head while in a car accident? Or, things like, so it's only asking the person to remember things that happened to them, not to self-diagnose a brain injury. Then if a person said, yes, that thing happened to me, then subsequent questions ask about whether there was a loss or an alteration of consciousness. And through that structured screening tool, we were able to identify what would be considered like a clinically diagnosable traumatic brain injury. Now, that core BISC that I think was developed in the early 90s had 20 of those contextual cues. What we've done since then is we've created 3 additional modules that are designed to query repetitive head impacts. The first asks about contact sports, the next asks about military service, and the most recently finalized module asks about intimate partner violence. We did this work in hand-in-hand partnership with survivors, with individuals who have lived experience with partner violence, with stakeholders, with experts, with advocacy leaders. We did that because we knew that we had to get those cues right. If the goal was to help people remember and accurately report brain injuries that may have been sustained in this context, we had to get that cueing correct, recognizing that there just wasn't going to be a correct. There wasn't going to be a single or only or best way to do it, but we knew that it wasn't our decision. It had to come from people with lived experience. And so what that resulted in is a community-based participatory research project that resulted in the creation of the BISC IPV module. I'll put it up here just quickly on the screen just so you understand how what we used to get to the research that I'm going to talk about next. But it's like I said, it's a set of cues that ask about contexts specific to partner violence, in which a person may have hit their head or had a strangulation type injury. And then if someone endorses any of those events, then we ask about loss or alteration of consciousness. What we did next is we applied this newly developed BISC IPV module to that ongoing study that I mentioned before, the late effects of TBI study. Now, it just happened that the BISC IPV was finished at a point in the LETB study, which is still ongoing, but we had already enrolled, we have it here, 156 people in the LETB study before the BISC IPV module was ready to roll. So we then introduced it, and then we collected data on another 142 study visits. That created this sort of organic research opportunity where we could ask ourselves, so what difference did it make? Did asking those detailed questions about traumatic brain injury and non-fatal strangulation, did that allow people to report injuries that they may not have previously reported? That's what the sort of broader IPV screening literature tells us, is that if you ask a person, hey, is everything safe at home? They're probably going to say yes, especially depending on the context and the relationship. But if you ask more detailed questions, and this is what many individuals with lived experience told us too, if you ask specific questions in a safe environment, in a trusted relationship, or in a context in which the individual feels safety and agency, they will report the history. Not everyone, not always, but we needed to see if we could move the needle. Could we do a little bit better at recognizing individuals with a history of IPV-related brain injury? What we found, the columns to the right here are the responses that we received among those individuals who were given the BISC IPV module. You'll see that 34% of the sample reported events of non-fatal strangulation. 22% reported IPV-related brain injury. Now, keep in mind that the LETB study is a cohort of individuals with traumatic brain injury. You had to have had a TBI to get into the LETB study. So this is not an IPV study. It's just a TBI study. It's like all the other TBI studies out there in many ways, in the sense that we recruited partly from the community and partly from specialty clinics where people with TBI receive care. We recruit now from the TBI model systems, national infrastructure. We didn't know until we asked these detailed questions that 34% of the women in our sample had experienced non-fatal strangulation. We didn't know that 22% had a history of IPV-related brain injury. In most cases, this was not the injury that got them into the study. We didn't know about it. So for all the researchers on the call, this is a hidden variable in our research. We didn't know that we had individuals in the study sample that had this exposure history in their lifetime, and that's a critical oversight. So again, if we don't ask carefully, we don't know, and this is a huge unmeasured confounder in our research. This is a hidden population in traumatic brain injury research. I'll just quickly mention too that the addition of those specific questions about partner violence also seemed to increase reporting of violent brain injuries in general. So that idea that cueing seems to enhance reporting definitely was borne out in this study. We have an amazing postdoctoral fellow, Dr. Nikki D'Souza, who decided to use the LETB study data now that with this greater characterization of partner violence-related brain injury, because she was very interested to understand cyclical trauma and the cumulative effects of lifetime trauma on TBI outcomes. So specifically, she was aware that adverse childhood experiences can contribute to IPV victimization and other violence. And she was also interested in how community violence, so just the neighborhood level interpersonal violence, might also play into symptomatology in this TBI sample. So again, keep in mind, this is all in a TBI sample from the LETB study. Essentially, she wanted to understand whether lifetime trauma, polyvictimization, increased the symptoms reported by individuals with TBI. She narrowed the sample to 70 women in the LETB study and used data that we had available on these indices of the constructs that she was interested in. And primary outcomes were PTSD, anxiety, and depression. Just to note, she did find that there were some differences between those in the LETB sample with and without a history of IPV. The women with a history of IPV had less education. They were less likely to identify as white. They were less likely to be working, and they were less likely to be unmarried. They did report more brain injuries, including non-IPV related brain injuries in general. Now, just to sum this up quickly, she found that those with a history of IPV reported a lot more adverse childhood experiences and much greater levels of current community violence. And she found that adverse childhood experiences and community violence predicted PTSD symptoms. Now, the way that she interpreted this is that essentially women with TBI and IPV history, they had greater exposure to both ACEs and community violence, which predicted worse PTSD symptoms. And when she looked at this as a sort of polyvictimization score, essentially assigning 1 point to each source of violence, childhood, community, or IPV, she found essentially a dose-response relationship with PTSD symptomatology. So this really, really underscores the importance of trauma-informed care for individuals with a history of traumatic brain injury that was sustained in the context of violence. That's an easy sentence to say, but making that a reality is going to take concerted effort, because a lot of times these are different silos, they're different worlds. Brain injury researchers, brain injury clinicians are not always trained in trauma-informed care, and that's a bridge that we really need to try to eliminate. I'm sorry, it's a gap we need to eliminate. The next thing I want to talk about, so I'm kind of giving an overview of some of the studies we've done in this space, because they come together to paint this picture that harkens back to, I think, some of the things that our very first panel today talked to us about. We know that during the pandemic, there was a bit of light shed on domestic violence. There was like a moment in time where I think people were talking about this a little bit more. We saw some press attention on this notion that violence may have increased, including violence in the home during the pandemic. Now we're starting to see what were sort of media headlines. We're starting to see the research supporting and affirming the fact that things got a lot worse for a lot of people living with violence during the pandemic. In early 2020, we were worried about this too. So again, as brain injury researchers and clinicians, we know that people with disabilities tend to be disproportionately victimized across the board and they tend to have more difficulty accessing even standard preventative medical care. And so as soon as those lockdown orders came through, we were worried about people living with brain injury and what this would do to them and to their health and to their well-being. And we learned about a group in Texas who had developed a study that was essentially the COVID impact study. And they were doing this on a huge nationwide community level, deploying this survey study all over the US. And we said, can we borrow some of those questions? And they were so collaborative. And what we did is we created a version of the study that mirrored their questions, and we added a few more that were especially relevant to traumatic brain injury. And here's what we found. Anela Valles led this work. She is now a doctoral student, and during this time, she was the project manager in the Brain Injury Research Center. These slides show what we learned just from the TBI cohort. So like I said, we kind of mirrored this study that was being done on a nationwide scale, and we deployed this survey all over our TBI networks in the United States. So all of the model systems of care sent this out. State Brain Injury Association sent this out. Some of you may have seen this or completed it. This slide and then the slides to come are just showing what we learned from that TBI sample. So here's a snapshot of who completed the study. We have a pretty diverse cohort of individuals with traumatic brain injury, ranging from mild to severe TBI, pretty well represented. About more than half the sample had sustained 2 or more TBIs. As you see, and as we well know in the TBI literature, depression and anxiety are both prevalent in this sample. We saw enormous disease burden and barriers to access to care during the pandemic. As you see, we see really high rates of all of these chronic medical conditions and mental health conditions, and unless all those numbers for saw a doctor are 100%, it's illustrative of gaps in care, difficulty accessing care. We asked people, like, what are the barriers to getting care? Why aren't you seeing a doctor for especially conditions that require active and frequent medical follow-up, prescription refills? Because it's alarming to see, that prevalence of medical comorbidity and alongside poor access to care. And as you see here, the reasons for not accessing care, many were pandemic related, although not all. Some were driven by social determinants of health that are unfortunately prevalent, especially in individuals with brain injury. Substance use, we were surprised, but pleasantly surprised that we didn't see a whole lot of people drinking more since the pandemic started, drinking more alcohol. But we did see really concerning trends in prescription pain medication misuse, where we're seeing people using more prescription pain medications than they were prescribed, or using prescription meds that were not prescribed to them. So at this point in the survey, we're already concerned enough. We were already concerned just based on the individuals we serve in our center. And then we get to this. We asked people living with brain injury across the United States about the physical and emotional and verbal abuse that they experience in their households. As you see here, this question, how often does anyone, including family, physically hurt you? Only 30% of respondents said never. Only 30%. And as you see, the rates of verbal and threatening, this paints a picture that is honestly worse than we anticipated, but was a real call to arms. I have to say, I must have presented this already. I don't know how many of you may have seen this slide already. I hope someone has. We shouted this from the rooftops, like, what a call to arms. As a researcher, of course, I have to acknowledge this is a single point in time. This is during a pandemic. This is an all TBI sample. What we needed to do next is we wanted to compare these responses from our individuals living with brain injury to that community-based sample, which we just recently had the opportunity to do. Brittany Engelman, who's a senior coordinator in our study, in our research center, has now been able to lead the data harmonization and comparison between the community-based sample and our TBI sample. There's these phases because on both our side and the community-based team, we added some more questions. And so there's this phase 1 and phase 2, but we ended up combining them because there was no justifiable reason to distinguish them, especially when we looked at the data. So again, the TBI sample compared to that community sample, they're a little younger, they're less likely to be female, which is important to keep in mind. Rates of brain injury are overall higher in men, but research participation tends to be more the women. But in this study, those with brain injury were less likely to be female than as compared to the community cohort. Let's see, there was quite a bit of missing data on race and ethnicity in the community sample, but it looks like the TBI sample had higher rates of Black and African American respondents. Here's the comparison, the direct comparison of responses on that question that I just shared. How often does anyone, including family, physically hurt you? This really hit home for us. The sample size here is greater, and you see that the prevalence of individuals who said that they are never physically hurt in their home went up to almost 46% who said never. Whereas 97% in the community sample said that they are never physically hurt in their home. Anything other than 100% of people saying that they're never hurt is unacceptable, but this really, I think, drove home for us the disproportionate burden of violence borne by individuals living with brain injury in the community. We were curious to just learn as much as we could, though, from this community-based comparison. And so we ran a bunch of additional comparisons. And you see here, the individuals at TBI, they had higher rates of heart attack, of stroke, of cancer. They had greater rates of depression, anxiety. They were lonelier. They have smaller social networks, fewer coping skills, and very limited health literacy. So 49% of those with a TBI have limited health literacy, compared to 5% of those in community samples. Now, for the purpose of this conference, we have to recognize that this is a study where we're slicing and dicing by those with and without a traumatic brain injury. But within the TBI community, there is a subset of individuals with the history of violence, of intimate partner violence, that when we put these pieces together, we are weaving this fabric that indicates that there is multiple sources of marginalization. There are many contributors to things that we know from the IPV literature are individual determinants and factors that can perpetuate violence. So I guess I just want to make that point that when we're talking about individuals with brain injury, we need to always keep in mind that there may also be these other sources of marginalization present in their life, and that a not insubstantial proportion of individuals living with brain injury have a history of intimate partner violence that they may not have shared, especially if you have not asked. Okay, so back to the story about traumatic brain injury and dementia. This is of great concern for many individuals living with brain injury. And as I mentioned, it's hard to talk about this stuff without talking about CTE, because CTE has just really dominated newspaper headlines when it comes to head injury related dementia. Some of the first studies were published in the mid 2000s. And we've, since that time, it's been on the cover of GQ. We have a whole movie with Will Smith. And you see here, this final little figure shows how research on CTE and contact sport athletes, mostly men, has just flourished, as has funding. We have not seen this in intimate partner violence related brain injury research, period. We have not. However, we've seen some other things. stay tuned here. Okay, just let me back up for a second. What is CTE? So CTE is a neuropathologic diagnosis for which we have a consensus-based definition. I'll skip ahead here because we just recently in 2021 published the updated consensus definition for this postmortem condition. It can only be diagnosed in brain tissue. This is not a clinical condition, although there are symptoms that have been described in individuals who were diagnosed postmortem with CTE. CTE is a pathological entity. It's hyperphosphorylated tau that aggregates in unique patterns and distributions in the brain that make it different, that make it distinguishable from other diseases, including other tauopathies that include Alzheimer's disease. So CTE, it's different. It does look different. We're learning a lot about it really quickly, thanks in part to the amount of research funding that we're seeing. Now, I need to emphasize here, almost all of what we know about CTE has come from American football players. We're starting to see some more research in rugby players and soccer players, military service members, where we're not really seeing so much CTE. We're seeing some other really interesting, like astroglial scarring and different pathologies. Full stop, all of these studies are pretty much, not all, but most are in men. I've heard people say, including some really smart people, some really well-intended people, that gosh, IPV must just be like the women's equivalent of football, because it's also this source of repetitive head impacts. It's probably also going to cause CTE. I think that I'm preaching to the choir when I say this, but to equate violence in the context of intimate relationship to repetitive head impacts in a sport, where at least in a lot of cases you get a medically supervised timeout and some advice about when to return safely. It's the most, to compare these things, I think is one of the most dangerously ignorant things that I think we can do. So let's stop. That said, it's a fair research question, right? So does the exposure to repeated head trauma that is sustained by some individuals in violent relationships, does that result in CTE neuropathology? There's one study that found CTE type neuropathology. Hard to get pathologists to agree on things, but there's some, I think, disagreement about whether this quite would meet CTE criteria. There's also some uncertainty around other exposures this particular woman may have had in her life, in addition to partner violence. But again, let's just play this out. Is CTE a primary pathology of intimate partner violence related TBI? We had a very unique opportunity to partner with the New York City Office of the Chief Medical Examiner to conduct a consecutive case series of brain tissue coming through the medical examiner's office from individuals, women. We ended up focusing exclusively on women in this first study to begin to characterize the neuropathology of partner violence. This slide depicts the postmortem protocol of the late effects of TBI study, which is what we applied to this case series. So we take the whole brain and we scan it at ultra high resolution in an MRI machine. That allows us to see every lesion of potential relevance in the brain and to carefully identify the regions that require additional histopathological analysis. This is very different from a standard neuropath workup where essentially the same regions of every brain are always studied all the time the same way with the same reagents. And we knew this required a much more comprehensive approach because humbly we weren't sure what we don't know, and we needed to essentially cast a much wider net. I've taken out a lot of the slides here because I want to just focus on the findings. I'll cut to the chase. We did not find CTE neuropathologic change in any of the women in this study. We found a little bit of Alzheimer's type neuropathologic change only in the very oldest case in the series, we found an enormous burden of traumatic axonal injury, of gross traumatic brain injury, like bruising, old blood, a lot of things that are sort of pathological indicators of remote brain injury. We found a lot of vascular injury as well, so cerebrovascular disease in the brain. I have to point out, this was a very young cohort for an autopsy cohort. Those other cohorts that I talked about in the very beginning, average age of study entry was like 70s, age 70 or so, 75. Average age of death was like late 80s. The average age in this cohort was mid 30s. These are young women. So the amount of brain pathology that we saw in this cohort was shocking. It was shocking. Maybe it shouldn't have been, but it was quite appalling. I don't know if I took out the slide. I did. I'll also just mention that there was a lot of comorbid disease in this very young cohort of women. Substance abuse disorders, mental health concerns, hypertension, diabetes, HIV, AIDS. There were a lot of comorbid medical conditions, epilepsy, which we know is often a consequence of traumatic brain injury. So we are talking about a very, a cohort of individuals who were, I think, systematically unable to access the care that they needed to prevent and to treat medical conditions. We, again, as researchers, you can see this theme, right? Where I have these two hats on. I'm a clinician treating individuals, and I'm also a researcher. So as a researcher, you say, okay, we had this sort of surprising finding because a lot of people thought we would find CTE and we didn't. So we reached out to our colleagues in the Connect TBI network, which is a center without walls, bringing together 13 leading institutions to study the neuropathology of brain injury, and colleagues at the University of Manitoba in Canada. And we replicated those findings completely. So we added an additional 70 archival IPV cases, similarly young in median age, and we found no CTE neuropathologic change, and we found evidence of vascular and white matter pathology. So this is not CTE. It is also very much not nothing. So let me just stop for one moment and say, this paper just came out a few days ago, and I've been asked by a lot of people, is this related to the clinical symptoms that we see in survivors of IPV-related brain injury during life? It may very well be. That's not what we studied here, but yes, with this burden of pathology, it is quite likely that this pathology contributes substantially to the challenges that these women faced during their lives. So I think the message there for people with a history of IPV-related brain injury is let these particular findings be validating in that sense. It is the case that organic changes in the brain can change the way that we feel, think, and behave. You're not just stressed, you're not just tired. There are things happening here. I think at the same time, though, we have to acknowledge that brain injury is enormously heterogeneous. Not all NFL players get CTE, right? Some survivors of severe traumatic brain injury recover completely. So this case series that came primarily from medical examiners' offices is essentially selected for those with the worst outcomes. These are individuals who did not survive past, in most cases, their mid to late 30s and 40s. So that's important to keep in mind, because the same is true here, wherein many individuals who have a history of brain injury resulting from partner violence will and do recover completely. And I think that it's really important to temper the way that we think about and talk about findings like this, because it is not helpful if we send a message that everyone with brain injury has impairments. It's simply not true. We don't see that in any other cohort, and it can be harmful, I think, to IPV survivors who are already trying to navigate the court system and can have implications for custody and other things. So we as researchers and clinicians need to be careful about our messaging. But gosh, this is alarming. It's alarming. And so I'm going to end on a note of what next, what now. This mess that you see on the screen here, this is a beautifully conducted study that essentially illustrates that the correspondence between brain pathology and clinical symptoms is a mess. So, and we see this all the time clinically too. We have individuals with severe impairments who on autopsy, their brains look beautiful. And we have people who were doing pretty well cognitively and neurobehaviorally, and then their brain is ridden with pathology. And so that's an important thing to keep in mind as we do this type of work, that the correspondence is imperfect. Even in Alzheimer's disease, which is the most widely understood of all dementias, the correspondence between diagnosis during life and postmortem pathology is far from perfect. There are so many things that contribute to degenerative diseases, and their relationships with cognitive decline and neurobehavioral decline are really still being understood. And other than brain injury, there are, of course, a ton of other factors across the lifespan that impact dementia risk. This is a graphic that came out of the Lancet Commission on Dementia Prevention, Intervention, and Care, which for the first time in 2020 acknowledged traumatic brain injury as one of those life course contributors to dementia. Now, there is a way in which this is an opportunity. Traumatic brain injury is increasingly being considered a chronic disease process. TBI does increase people's risk for a lot of other chronic medical conditions, many of which are treatable. So the message that I have for people who are in a position to offer care and resources is to treat the person. You never know where in this whole schematic the individual in front of you may fall. They may be still recovering. They may be very stable. They may be declining. They may have recovered fully. They may have recovered imperfectly. And the thing that we do is we treat the person, whether it is a symptom of brain injury or dementia or PTSD or something else. Our role as service providers is to use the tools in our toolbox to provide the treatment for the symptoms that our patients are experiencing. We have been fortunate in our research center to develop several neurobehavioral interventions for brain injury, one of which has already been adopted for standard care for individuals coming back from the current conflicts in the Veterans Administration. And a component of that is something called emotion regulation. It's, as many of you know, emotion regulation is one of the most consequential sequelae of brain injury. People a lot of times think of cognitive impairment as what really gets in people's way, and that's absolutely true. But what we find as clinicians is that it's the short fuse, the inability to regulate emotions, the anger, the rage, the inappropriate behavior, those are the things. The inability to regulate one's behaviors and emotions is what destroys social networks. It's what makes it difficult for people to keep their jobs. It's what can be, in some cases, most personally consequential. And so we have this intervention that we developed that is intended to treat post-TBI emotion dysregulation. We offer it over the internet because that allows it to reach more people. What it is a skills-based intervention that's based on cognitive behavioral therapy, which many of you are probably trained in. And it's designed to allow people to become more aware of the origins and meanings of their emotional responses, train people to essentially monitor and evaluate their emotional states, and then deploy personalized strategies in the moment that allow them to maintain the control and behavior that they're proud of. This is just a schematic of the way the intervention is trained, but I'm sharing this with you on this call today because Dr. Kayankova from our center has led a lot of this research and has carried this through every stage of research, having just completed a full randomized controlled trial that hasn't been published, but it's some of the strongest effect sizes I've seen in a behavioral intervention ever in this space. And so we're very enthusiastic about it. And she's now leading a study that involves training clinicians to essentially learn how to give this intervention. And I'm sharing this because my experience has been that in many cases, survivors of partner violence, particularly given the multiple and mutually exacerbating effects of life course trauma, tend to struggle with emotion dysregulation. And so if there are individuals on the call who are clinicians treating people with brain injury, and you're interested in potentially learning how to give this intervention in your own clinical setting, then there's that QR code thing. I think I don't know, you take a picture of it or whatever, and you'll be able to learn more about the study, or you can just email Emily Blunt, who's the CRC, or you can email me. I want to stop there. We have such a wonderful lineup, and I know there are amazing speakers coming tomorrow as well. Thank you again for this opportunity, and thank you to everyone who has been a part of these studies, and for the individuals who've participated, without whom we could not have done any of this work.
Wonderful. Thank you, Dr. Damso-Conner. Really interesting, fascinating stuff. And I keep on thinking back to our panels this morning in terms of Dr. Lifshitz saying, the data speak, and yours definitely do. So thank you so much for sharing this with us. Just want to give folks a heads up. We do have our next speaker coming up here soon in about a minute here. But if you do need to take a break, we understand. Please feel free to do so. And also, if you have any more questions for Dr. Damso-Conner, feel free to pop them into the Q&A, and hopefully Dr. Damso-Conner, if you don't mind taking a look at them, when you got a chance and getting back to folks, that would be great. Otherwise, we'll prep for our next speaker.
Thank you.